To all of you for joining today. This is actually the third in a 3-webinar series, and today we're going to be closing it out with the subject of how home care wins in the bundled payment era. And for those of you who might not have seen the first 2 webinars or missed one of them, I'll try to summarize some of the key points that lead into today's discussion, and hopefully for those of you who have attended all 3, we'll try not to take too much time on those, so it'll be mostly new information for you. We do have a little bit of housekeeping to cover here at first. And so the first thing is just to explain that on the webinar you are in listen-only mode. So the only way that you could communicate with us is through the questions panel on your GoToWebinar console. So you could click, I think there's a little you'll just see the questions console and you could type a question there. And if you have a question at any point during the webinar, you could just type it in at that point, but we will be addressing the questions at the end. And I'm your speaker. I'm Ken Accardi. I'm the CEO of a company called Accardi. We mostly focus on non-medical home care, care transitions, and other aspects of post-acute care that are complementary to our friends at Healthcare Synergy. So today the learning objectives are, again, to review the changing payment models that are essentially making the way that we have to think about our offerings and how we make money. We have to think about all those things differently. Second is just a recap from the second webinar what some agencies are doing that is more entrepreneurial and how they're really thinking about the skills in their agency and the strengths of their agency and what kind of offerings they could make to hospitals that they may not have made in the past. And then we'll kind of get into the meat of today, which is to learn in the way that I envision that healthcare at home in the future is going to be organized, and talk about how actually the fact that these new payment models are coming out could be looked at as a positive thing and a way that agencies could actually increase margin by providing better care at lower cost, and that's really what we're going to focus on today. Really the first webinar was informational, the second one was entrepreneurial, and this one is kind of a business model innovation discussion and really looking at the financial aspects, but it'll be very clinically based. And really what we hope that this will do is it'll help your agency to think about where you want to go in the coming years and what strategic either changes you want to make in your agency or perhaps partnerships with others in your community. So this is a big slide that I've used in all 3 webinars. I actually got it from a guy named Dr. Josh Luke, who is an expert on all things related to care transitions and bundles. And so he really kind of summarized it very nicely here about what the thinking is on post-acute care. First and foremost, we really never want a readmission. So having somebody come back to the hospital should really be a last resort. And to kind of re-summarize a lot of these changes in payment models, it's the hospital that is going to be paying out of their own budget for the entire care episode, which includes the surgery, the hospitalization, and the post-acute care. So if somebody readmits and they're in the hospital for a couple days because, let's say, they had an infection or a complication, then that all comes out of the hospital's own pocket. So really a readmission is essentially 100% penalty. It's 100% cost to the hospital now, and this is obviously something that they want to avoid at all costs. But next is, I guess I looked at some statistics where approximately, looking at joint replacements in 2015, approximately 40% of people who had a joint replacement went to skilled nursing last year. And as we'll see in a slide or two, a discharge to skilled nursing is not going to be profitable for the hospital out of this bundle because they're not going to have enough money for it. So we expect that in the coming years that we're not going to eliminate discharges to skilled nursing, but we're really going to be thinking first about, hey, could we send this person home with some help with their activities of daily living, which would be much less expensive than putting them in skilled nursing, and that's going to be the new mindset. That same individual I referred to, Josh Luke, has predicted that by 2018 that the skilled nursing facility discharges will drop from 40% to 20%. So, you know, of course here with Healthcare Synergy, most of our customers and people we work with are in the certified home health arena, and we might say, well, that's great news for us, you know, so we're going to get more discharges into home health because of less going into skilled nursing, and that's great, but there's also a lot of pressure on home health through things like the home health value-based purchasing program that just went into effect in 9 states and other things that is saying, you know, hey, you know, home health, we need you to think differently as well. And what is at the bottom is that there's kind of some new winners in this equation, which are non-medical home care, private duty, and assisted living. And I guess I'd say that these are new winners because, you know, in the past, if you are in a non-medical home care agency or you speak to people who are, they've kind of had the idea that, you know, hey, we're not really part of healthcare, you know, we're not part of that care continuum, you know, we're really, you know, more of a social model of care or, you know, helping with activities of daily living, and we're non-medical. But if you think about this equation where, you know, somebody who might have been going to a skilled nursing facility and is now going to discharge to home, that if they don't have the help with their activities of daily living, there's probably a very likely chance of a readmission. I'm a relatively young person compared to the people we deal with in our agencies, but I actually, you know, due to a congenital issue, I had a knee replacement last year, you know, and I was of course able to come home, and I have, you know, my wife and my kids, and I was pretty mobile and didn't need a lot of help. But, you know, surgery does take a lot out of you, even for me, a younger person, and you know, so mobility is tough, and, you know, really I did need help with activities of daily living. So this is kind of the picture that summarizes the way post-acute care is moving. And I've done some of this already, but just to recap some key points from the previous 2 webinars. First is that in 2016, 30% of the discharges will not be Medicare reimbursed. So this was a lot of the discussion in webinar 1, is that it used to be that for anybody 65 and older, that it was going to be Medicare reimbursed, and that they would really just kind of choose, well, is this person eligible for home health, or are they, you know, kind of higher acuity and lower mobility and need a skilled nursing facility. But already in 2016, 30% of those discharges are being covered instead by either accountable care or bundled payments. And just to summarize what those are, so accountable care organizations are healthcare systems that take a fixed fee per patient per year, essentially, and they have to, you know, kind of deal with those finances across their population and provide all the healthcare services. So if somebody's part of a big accountable care organization, yeah, you know, and it's been this way with organizations like Kaiser and Geisinger and the Mayo system for years, you know, those people are paying out of their pocket, but, you know, they're looking for what's the best recovery I could have for this person at the lowest cost. Now, bundles are something different, and I have a really good detailed slide on that in a minute, but these are Medicare initiatives where, as I described a minute ago, there's going to be a fixed fee for everything having to do with that procedure, you know, and the one that is in the market as of April 1st in a number of states, a large number of states actually, is bundled payments for joint replacements. So in a lot of states already here in 2016, that hospital is getting a fixed fee to cover the surgery, the hospitalization, and all the post-acute care. And this means that, as I said, the hospitals are paying out of their pocket. So winning means that we have to provide affordable offerings that don't result in a readmission, and we really have to rethink the mix of services that we provide in our care. And this paves the way for supplementing our skilled care resources with, you know, non-medical home care for the first time, let's say, as well as some automation in the form of either telehealth or a system we talked about last time called Foresight Care, which can make automated phone calls out to patients and see if they're in trouble with their recovery. And lastly, the best solutions will, apply the best service at the lowest cost, and that's really what it comes down to. So let's move on to the new material for this webinar, which is all about, how we win. And so first of all, this is the best depiction in simplest terms that I've seen for how bundles are working, and this talks about the joint replacement bundle. And to kind of summarize this, they're saying that the cost of the surgery itself on average is about $12,267. So let's say $12,000 for the surgery, and then there's additional costs for the hospital stay, which let's roughly call that $5,000. So what I'm basing this webinar on is kind of a base cost of around $17,000. But then if we look at the different options that people can be discharged to and look at the total cost of care, we see some scary numbers for the hospital has to pay, based on a budget of roughly $28,000 per patient. So if they send them to a long-term acute care hospital, the treatment for that patient is going to cost more like $74,000, almost 3 times. An independent rehab facility, I'm here in an area like Spalding Rehab, for inpatient care might cost them more like $41,000. Skilled nursing, $36,000. So, what we kind of see is that any scenario that's going to be profitable for the hospital is going to involve a discharge to home. So it's kind of home equals profit, and by extension or corollary, any facilities-based care is going to result in a cost, in a loss. And so the hospitals are going to need to find the best care that's going to offset that loss. Now we look here and we say, well, here I am, I'm home health care, $20,000. If they discharge to me, then that's going to be great for them because they're going to have this, almost $8,000 worth of profit. But if you think about what we're doing with our home health service, we're evaluating the person, doing home safety and things like that. And let's say in a joint replacement, we're making sure that everything's fine with the blood thinners. But essentially, we're stopping in after, let's say, the first week. We're stopping in once a week for 35 minutes and making sure that a couple things are okay and checking some vitals. And if now people are giving us that discharge for us to take care of, and that person may have in the past been going to a skilled nursing facility or a rehab facility, they're definitely going to need more care than what we typically do in the episode, with kind of the medical things. And again, just from my own experience, when I was in the hospital, I saw my doctor for about 5 minutes before my surgery. He told me, hey, here we go, great to see you, everything seems great. Of course, he was in the surgery. I was not awake at the time, so I wasn't, cognizant of, his being with me for that, just about an hour, maybe an hour and a little bit more when he was doing the surgery. And I saw him one other time on rounds the next day at around 6 in the morning for, again, 2 minutes. Okay, great, you seem like you're doing great, and that was it. So that's all I saw the doctor. And then if I think of, when I saw nurses, well, they came in, to give me my meds and that kind of thing. And, who I spent most of the time within the hospital was the CNAs, right? So they were coming in and, helping me with, with food and, and voiding and, kind of cleaning up and various things like that. And it's kind of the same in the home. It's like when you go into the home, you really need, care and help with homemaking and personal care, more than you need, on a personal level anyway, more than you need kind of the healthcare aspects. And then of course the healthcare does, in addition to, checking the INR for the Coumadin and things like that, it also, in a joint replacement, would involve physical therapy and those types of things, and that's of course very, very important to recovery. But I guess the point I'm trying to make is that we can't just say, hey, we're profitable for the hospital, everything's good on our side, and we don't have to worry about it. We really are going to have to be thinking, well, we're going to be getting higher acuity patients who might, historically have been going to a skilled nursing facility, and we're going to have to provide a combination of home health services and also, caregiving services to get the job done and help that person recover. So, premise two is that the math needs to work out for the hospital. So, as I said earlier, 40% of discharges last year went into facilities, and there's an assumption that that'll drop to 20%. But if we think of those different facility choices and the fact that even if they're in skilled nursing for a number of days, they might also need some home care after the discharge, I've kind of put together a math model. I didn't really put the math here, but just kind of summarized it, where let's say that we're moving to a future where 20% of these patients are going to have a total cost of $40,000, compared to the $28,000 that the hospital's paid. So essentially, on 1 out of 5 patients, they're going to lose $12,000, is what I'm contending. And and the other 20% that used to be going to a facility, they're going to be going home, and as I've said several times here, they're going to need help with their activities of daily living. And here I'm just making an assumption for this model that the hospital needs a profit. So they're going to work out their model to say, hey, I need all my costs for everything to work out to, let's say, no more than $25,000. So on 100% of my things, I end up with a $3,000 or $2,800 margin, because we definitely need to make profit on these services. So they're going to try to control their costs and offset the losses on these 20% by spending less on the 80%. And in the last webinar, we talked about lots of new and different ways that people are able to provide care, and with fewer nursing visits but more nursing support and technology, and we'll kind of summarize some of those here again in a minute. But kind of sticking with the math, if we go with this model, that the overall cost of the hospital is going to be willing to pay for the 80% of people who don't go into a facility, is going to be somewhere in the $4,000 range. And and if we try to say, well, typically in home health for the episode we get around $3,000, so we'll just keep the $3,000 and spend $1,150 for everything else, like helping with activities of daily living, that might not be a winning equation for us, because as I said, there might be some more need for supportive care than for nursing and therapy services. So we kind of have to think about what's the best mix to treat that patient. So in the last 2 webinars, I've concluded with this picture of what I've kind of depicted as the healthcare at home organization of the future. So I'm trying to stay away from calling it home health, thinking specifically certified home health, or call it home care, thinking non-medical home care. I'm calling it healthcare at home, and really trying to say, hey, this is what I see the future to look like, and that to really provide all of the care that somebody needs, it's going to take a combination of skilled visits, so this would be our nursing and our therapists, non-medical visits, so this would be our homemaking and care and personal care. And one thing that we're seeing much more is support from call centers. And then lastly, the last piece in the pyramid is the automated visits. And so here, the reason I've kind of depicted the pyramid this way is basically by cost. So like here, when we have an automated visit, like a check-in with telehealth, or an automated phone call out to the to that individual, that's very inexpensive compared to a skilled nursing visit. And so really it kind of comes down to the home health, or the healthcare at home organization in the future, having all of these different tools in their arsenal, and trying to say, well, if I could have each one of these types of services practicing quote unquote at the top of their license, providing any care that they're able to provide based on their capability, that I could try to drive things lower in the pyramid to have lower costs, and use my skilled resources where it's really most necessary. So now let's kind of break it down layer by layer and talk about what each layer is going to do. So here in our skilled visit layer, what I see in the future is that it's going to be more about evaluating the patients prior to discharge, and then really individualizing the recovery plan. So today through the OASIS form, there's some variability on how much need people have, but this is really a new equation. So let's say that, again, your company is being paid $4,000 for every every discharge, and you have to make sure that essentially none of them readmit. That's going to be the goal. I mean, today we've lowered it from around 24% 5-6 years ago to closer to 18%, so we've made some good progress. But really every readmission here is going to be a big expense for your customer, and they're not going to be happy with your organization. So we really have to make a good plan. And another thing is that there could be another payer in this equation, which could be the patient themselves. So there's going to be a lot of elderly patients who are willing to pay for some non-medical home care as part of this, and you could put together offerings that say, well, really we have the need to provide services that help you at a basic level with activities of daily living to help you not readmit, but you might also be able to afford privately some more non-medical home care services, so you could have more comfort and things like that. So that is going to be part of the equation, is to say, hey, we'd love to discharge you home instead of to a facility like skilled nursing. Can you pay for some home care out of pocket? And a lot of patients may say yes. So given that the old paradigm was that Medicare paid for everything, that question wasn't really being asked, and those people were just being sent to skilled nursing. But there is a mandate for patient choice, and there is this new payment initiative that's moving things in a new direction. And then finally, after that initial evaluation, what we have to say is, well, we don't need necessarily a nurse or a physical therapist to do every visit that we might have historically. There might be some things that, for example, the home health aide can do, or maybe some visits that we could totally eliminate. So that's what we would do in the skilled visit layer. In the non-skilled visit layer, as we've described, we would provide the non-medical care assistance that is needed, and we would also, really try to look and say, well, on things that I'm doing with my skilled visits today, because I'm only a certified home health agency, there are probably some of those visits that can be eliminated in favor of sending a non-medical home care person. And it's kind of a way of rethinking and saying, well, if the nurse was going, let's say, 3 times the first week and twice a week for the next 3 weeks, can we figure out a way for that nurse only to go twice the first week and once a week for those next 3 weeks? And there would be a lot of savings, and and that kind of thing. And also, I mean, keep in mind that we want to maximize patient satisfaction, and the more care and services that we're providing is going to give that patient the better impression of our satisfaction. And when we get ranked with certain things like the HCAP surveys and things like that, that's going to help us, and that's really going to help us a lot as more and more of this becomes democratized, I would say. So then we go to the call center layer, and really the whole idea here is that if something's wrong, we want the call center to be our first responders to see if we can, when something does pop up, see if we can intervene without having that readmission. But also in a call center, we could drive adherence, so make sure that people are filling their meds, they're taking their meds, and drive behavior change, right? So you could have people in the call center, and again, they could be paraprofessionals or social workers, and or people who are trying to move up in their career from being an aide. You could have a set of different skills in your call center, and you could go out and get a lot done, and do a lot of monitoring and following up of alerts. So all these things could be done in a call center, and keep in mind that somebody in a call center can potentially interact with something more like 50 patients per day, whereas a nurse is generally seeing 3 to 4 patients per day in the field. So so think about having more call center deployed services in our mix. And then finally, we talk about the automated visit layer. So we can have telehealth, so this would be for your higher acuity patients. So let's say somebody who discharged with congestive heart failure and is a high risk, and there are telehealth solutions where, for example, they would have a scale and a blood pressure cuff that are in their home, and they're expected to weigh themselves every day, and so we can see with with objective evidence that they've gained some weight and they might be having trouble diuresing their fluids. So that would be kind of a telehealth solution. But then there's also these solutions cropping up, and and actually my company makes one of these, and so I'll be very clear about that. And I have some more detail on the next slide. But we do see this automated phone call model as being very, very effective, and we've seen some very strong results so far. So kind of taking that same example, somebody who maybe they discharged with a joint replacement, but they have a history of congestive heart failure, this automated phone call could ask them questions. Hey, are you having any pain or bleeding at your wound site? And they can answer that with their touchtone phone, 1 or 2. But given that they also have a comorbidity of congestive heart failure, we can look at kind of the red flags of heart failure more from a subjective and social perspective than an objective perspective. So we could ask a question like you see here: are you more or less congested since our last call, right? And if the person indicates I'm more congested than last time, and then they further indicate maybe through a follow-on question that they have a loose and productive cough, that we could escalate to the call center, and they could call and figure out, and and that might turn into a call to the doctor who says bolus the Lasix, and they have them increase the diuretic for the day, that kind of thing, or it might result in an extra nursing visit and that kind of thing. But at this point you kind of plan for the best, by setting up the episode based on the acuity of the person. But something comes up, this is a way of getting an early warning sign, and and really trying to intervene before we're back in the emergency department. So just a little bit about Foresight Care. So again, this is our product, so I put that as a disclaimer here. But what we do is that it's really simple, where we put the person in the system and you select all of their comorbidities. So again, a lot of the people we deal with in their 80s, even if they had a joint replacement, they do have other things going on. They have asthma, they have urinary tract infections, they have diabetes, they have CHF. So you put in that case mix and enroll them and transition them, and then it just automatically monitors them by calling them on the phone. And if something's wrong, you get an alert, and you can provide that early intervention as I described. And again, if we kind of think back to the cost structure in the pyramid, and I think that's where I go next, like an automated phone call is roughly going to cost you about $1 per intervention, whereas a telehealth, kind of daily check-in on that scale or blood pressure cuff, it's going to cost you more like $5 per intervention. A call center call might be more like $8 intervention. A non-medical visit, even though we generally, in non-medical home care are charging in the lower 20s, here fully burdened, we're probably at more like a $30 cost. And then for skilled visit, with the back-end admin costs, might have a cost of around $125. So, so really we want to look at, how do we come up with, the mix of skills in the pyramid as we described to come out with, the best care for that person at the lowest cost. And, and just like I talked about, the hospital has to kind of look at, well, what's their mix? Well, we see 20% going to facilities-based care, or, maybe in some hospitals it's going to be 30%, and some 15%. They kind of have to look at their mix and their blend, and then you and your agency would have to look at your mix and blend as well. And there could be, some people who, if that person, like I said, historically might have gone to, let's say, skilled nursing, they might need more non-medical home care, more nursing visits and that kind of thing. So, you can't really think about, here's our cookie cutter approach for handling every single patient who's discharged into our care. And some of them are going to lose money for us. So if we're being paid around $4,000, there could be some 20% that we're losing money on, just like the hospital. 20% are costing us $6,000. But here, and this is just an arbitrary model for example purposes, but if we, let's say, can get 30% at $3,500, 30% at $2,200, and and let's say those youngest, later 60s people who are otherwise very healthy and able to, kind of just recover from that joint replacement very, very quickly and get into, kind of going to the physical therapy center instead of needing home health PT. We could have maybe 20% of our people are only $1,000. So if you kind of run this math through with these percentages, then we've come up with a blended average cost here of $3,110 per patient, and based on again a payment a little bit over $4,000 as I described a few slides ago, that would give us a blended margin of 25%. So I guess what I'm trying to kind of offer here is that I think that the majority of agencies are going to be scared by this. They're going to say, we do it the way we do it. We only do this kind of care, and we're used to getting the amount we're getting, and all that sort of thing. But the really, kind of leading agencies of the future are going to be thinking of it and saying, hey, this is great for me. If I could, first of all, prove with evidence to the hospitals in my area that they could give me 80% of their discharges of everybody who had a joint replacement, and I'm going to have a super low readmission rate, 5% or less, which, by the way, is not hard to achieve with this model. I know one company doing this very effectively, and they have an overall 1.7% readmission rate across a 24,000 person population. So it's very, very doable. So you can kind of get to those, super low readmission rates, and and they love this model, this agency that I'm referring to, because they get to figure out the best way to provide care, and if that care is going to cost them a little bit more for some patients, they're willing to do that. But in other cases, they're able to really provide a much lower cost by having non-medical home care, people center nagging them to make sure that they're taking their meds and that they're behaving the way they need to and complying with their discharge instructions and things like that, and then also supplementing with telehealth and automated phone calls. So really, kind of if we look at this as the glass is half full or as an optimist, there's really ways for our agencies to win if we're willing to think differently from a strategic perspective. So I'm going to kind of summarize here real quick. I kind of put this just to remind you that if you do have some questions, this would be a great time to put them in the questions panel, and we'll come to those in a few minutes. But again, just to kind of talk about some conclusions are that we have new payment models and combined with the patient's right to choose, and all of this is driving lower post-acute care costs that drive readmissions and more people going home, and less and less to facilities, and everything we talked about here. So then discharges will be to home will be profitable, and and this can increase your home care referrals by 25%. So if again, just kind of going with the math, that if 60% of people historically have been going to home, and we expect by 2018 that 80% of people will be discharged to home, then we have a very nice, actually that's a 33% increase from 60% to 80% of the total population. So you're going to get more opportunities for people to have health care at home rather than in facilities, and that's a great upside. And but then you kind of have to look at how do I provide the services, and by providing skilled care, non-medical, call center, automation, you can provide better care with that combination of services at a lower cost and have fewer readmissions and higher patient satisfaction. And of course, that's what it's all about. And this is what I expect that winning agencies are going to do as they move into the accountable care organization era. So here on my next slide, I'm going to talk about where I see things going next. So this is kind of really timely for 2016. This is all about bundled payments, accountable care organizations, and the home health value-based purchasing. Are really the top of mind things that are going through our minds as home health agencies today. But really, if we kind of look at the bonus, where I see things going tomorrow, and I think this is just logical, is that this model, if we can really be successful in this model, we could win in other ways as well. First of all, if you could execute this model, you're going to dominate in post-acute care. However, you have to think as well that if you had that pyramid of services, that you could also get a lot of these discharges could potentially be ongoing clients. So instead of just having that person for the historical 60 days, or some of the bundles actually require 90 days of care without a readmission and that kind of thing, and you'd be paid for that, that these could be, people who are working with you, ongoing. So a lot of these people, they're going to need, care for the rest of their life, and if you have non-medical home care services and things like, phone call check-ins for them to see how they're doing, you could actually keep them, with you, and that so they could translate into ongoing clients. And you could also make it better. So you could say, hey, I'm a non-medical, we have non-medical ongoing home care, but we could also supplement with our skilled services, and we're going to charge you a premium for that. And in our low-cost automation and things like that. So you can kind of look at using this pyramid, beyond just the post-acute episode and into the future. And then there's really two other, very, kind of prevalent discussions in the overall healthcare continuum. There's a lot of discussions about population health management and chronic care management. There's a reimbursement now to primary care for ongoing chronic care management, and there's a lot of thought in this whole accountable care organization model about population health. So how do we take care of, let's say we are Kaiser or something like that, and we have 40 million lives we need to take care of, and we're getting a fixed fee per life in our system. Then there's going to be a lot more looking at who are our highest risk people for admissions that could be avoided, and and really where healthcare for those people should be is at their home. And if you are able to provide that pyramid of healthcare at home services, you're going to be exactly who people like Kaiser and Mayo and all the accountable care organizations and people doing bundles are going to look for to be their partners. And and again, as I've kind of described a few times, you can support and monitor these people, with a lower per member per month model, and that could really turn into good profitability and growth for the forward-looking agencies who get this done. So that's all I have for today, but let's jump in and see if there's any questions in the question panel. And okay, so it looks like I have a few here. I'm trying to figure out how to make my question panel bigger. 1 second. So it says, how does an agency take advantage of the trend in care transitions? Okay, yeah, so actually that was really the subject of webinar number 2, was about managing care transitions and kind of looking at this question of how do we get people from hospital to home successfully, and the answer to that, and interestingly, webinar 2 was 5 ways of doing that. So we talked about 5 models that work, and there are lots of answers to the question. So it could be using an evidence-based solution like the Eric Coleman model or Dr. Naylor's model, or it could be kind of a combination of partnering with the hospital, with your non-medical home care agency, and saying, hey, we can have a combination of caregivers, aides going in and checking in on the person, also supplemented with something like Foresight Care, calling them and checking them in. And we as a non-medical home care agency, we want to partner with your hospital-based discharge nursing staff. So if we have something to escalate, that you can help us out and provide the medical services. So there's really, the answer to your question has to do with really what skills your agency offers. But I guess I would encourage everybody on the phone to to be participating in some way in providing care transition services, moving into the future, because as we've described, especially with that graphic from the Wall Street Journal, this is really top of mind on all hospitals now. Is how do we discharge people and have them recover successfully? Because if they come back to us, it's going to come out of our pocket and it's not going to help us. All right, let me see if there's any other questions popping in. Okay, it looks like we have a new question says, what do I need to think about before I implement something like PostAcute Care? Okay, yeah, so PostAcute Care, again, I mean, that's the automated phone calling system. So again, it kind of depends on who you are, but if you're, let's say, a certified home health agency, then what you want to be thinking about is, if I could, kind of ask the patient how they're doing on a continuous basis, how can I have fewer visits in my episodes, right? So that's kind of the question there. And then also, if, let's say, the person has mostly recovered in 3 weeks, but I need to provide 60 days of care or 90 days of care, how can I make sure that they don't fall off the wagon by having these automated phone calls go out? So if you're kind of on the certified medical side, it's really about, how could this be my fire alarm, if you will? So, so it kind of helps me know if I have any, any escalations that could get me in trouble with a readmission. If you're a non-medical, home care agency, then you might be thinking a little bit differently. You might be using it as a differentiator. So, what happens a lot with non-medical home care, as you know, is, somebody's mom falls. Like if, my mom's in Florida, I'm in Boston, so if my mom fell and injured her hip, I would probably fly down today and try to help her and things like that. But, then I would be shopping for non-medical home care. And if I went and talked to 3 agencies and they all look pretty much the same to me, but one of them said, but we have a persistent monitoring solution where we check in with your mom based not only on her hip thing but her other health conditions, and we can escalate to you and to her care providers, her doctors, if we get some alerts, then I would think twice about choosing that agency. I might even pay more for that agency. So so again, I apologize for having to give multiple answers to the same question, but you really have to kind of think of all these things in the context of who you are today, in your agency and where you're going. Okay, it looks like another question came in. Can I use these automated visit systems with my Synergy software? Oh, that's a great question. Yeah, so if you're a healthcare Synergy customer, then absolutely yes. So you could use your healthcare Synergy for managing all of your certified home health nursing care, and you could supplement with, with PostAcute Care, and it'll make the phone calls, and then those alerts will go directly to your, it depends on how the agency wants to do it. Some agencies have a centralized person who sees all the alerts, and then other agencies, send the alerts to the nurse that's overseeing that case. But the clear answer to your question is absolutely. If you're a healthcare Synergy user, you could supplement with PostAcute Care, and we're also working with them to make that very easy, so there's no, for example, re-entry of any of the patient demographic information and things like that. So great question. All right, I think that is all the questions that we have at this point in time. So I'll just take this last opportunity to thank you once more, and especially for anybody who's been to multiple in this series. And if you have any feedback for us, let us know. And otherwise, I will say thank you to all of you for attending today and to the other sessions, and good luck, and we'll talk to you soon.